Historically, at Lahey Hospital and Medical Center, we have used the Blakemore gastroesophageal tamponade tube. At this time, we are transitioning to the Minnesota tube, which is a similar, though not exactly the same style tube. Both tubes feature both a gastric balloon as well as an esophageal balloon. These balloons are used to tamponade patients who are experiencing gastric and or esophageal varices. Both balloons require inflation. The biggest difference is at the port sites. The Blakemore has 3 ports, a gastric aspirate port, as well as 2 balloon ports. The gastric balloon as well as the esophageal balloon. Lahey now has available the Minnesota tube. You'll notice it still has a gastric balloon as well as an esophageal balloon. The large difference, though, is the 4 ports at the top. You'll see there are still balloon ports for both the gastric and esophageal balloons. However, you'll notice there are 2 large aspirate ports, one for gastric aspiration and one also for esophageal aspiration. As you can see here in Attachment A to the Esophageal Gastric Tamponade Tube Guidelines, we have the 3-way stopcocks with a setup in order to allow for pressure monitoring for the balloons, as well as a safety mechanism to prevent accidental deflation. Using Attachment A for reference, the 3-way stopcock should have a clear clave, a red dead-end cap, and the blue tapered nozzle attached in order to prevent accidental deflation of the balloon, as well as enabling the provider to check pressures of the balloon. You'll see you'll need 1 for each of the balloon ports as assembled with the clear clave across from the 3-way stopcock indicator. Once assembled, the blue tapered end will go into the balloon port. The clear clave will go for pressure management, and then the red dead end cap will prevent accidental deflation if the 3-way stopcock is accidentally turned in such a way that it remains open without anyone at the bedside. Once you have your 3-way stopcocks assembled, you want to remove the gulf T from the direct port in line with the balloon and replace it with the 3-way stopcock as assembled. It should go in each of the balloon ports only, leaving the aspiration ports open for suction. Please make sure that they are tightly engaged by removing the T, leaving the subsequent T in place, and then inserting the blue end with a snug fit. Once your 3-way stopcocks are in place, use a 60 milliliter syringe to inflate the balloons with 50 milliliters of air in order to check the balloons for leakage prior to insertion into the patient. Using the clear clave, inflate the balloons with the stopcock oriented to the red dead end cap. You should see the balloons slightly inflate as demonstrated in the video. Using a basin filled with 2 liters of sterile water, insert the inflated balloons and the tube as well as the ends with the stopcocks into the basin and completely submerge them. Carefully inspect first the areas nearest to the stopcocks, looking for any air bubbles or air leakage all around the stopcocks themselves, as well as the clear clave and the red caps. Once you've inspected those areas, you're going to move on to the balloons, inspecting the areas all around the balloons themselves, looking for any signs of air leakage such as bubbling. If you note bubbling coming from the aspiration ports as seen, that is not considered a problem, as one of the ports may be above the water. Once you've completed the testing for air, you're going to remove all of the air from the balloons by deflating them using the clear lure lock and the 60 milliliter syringe. The balloons must be completely deflated prior to insertion of the gastroesophageal tamponade tube into the patient. Once the balloons are completely deflated, the 2 ACE connectors should be attached to the aspiration ports, one to the gastric aspiration port, and a second connector should be attached to the esophageal aspiration port. This will allow for irrigation and suction to continue during placement of the tube. Once the balloons are completely deflated and the tube has been successfully placed in the patient, the provider will place 50 to 100 milliliters of air in the gastric balloon in order to secure it for X-ray. The X-ray confirmation is required because the gastric balloon will need to be inflated to approximately 250 to 500 milliliters of air in total, and the esophagus cannot tolerate that amount of air being placed safely, nor that amount of pressure being exerted. Once the provider has confirmed the location of the balloon using X-ray, the provider will inflate the gastric balloon up to 500 milliliters of air full. This video demonstrates the inflation of the balloon up to 500 in order to illustrate the approximate size of the balloon required to anchor the tube in the stomach. Once the balloon is fully inflated, it will be held using tension up against the gastroesophageal junction in order to secure the tube safely. If the provider decides that the esophageal balloon needs to be inflated, he or she should use the cuff manometer found inside the Minnesota supply box. This cuff manometer can be attached to the clear lure lock on the end of the esophageal balloon and can be used to safely inflate to the correct pressure. As pointed out here, there is an inflation valve that is activated and a red deflation valve, and pressures are available on the front of the face. Using the clear lure lock, make sure that the stopcock is angled towards the red dead end cap and the cuff manometer can be attached. The handle can be squeezed in order to inflate the esophageal balloon. Because the esophageal balloon should be inflated to a particular pressure, not a particular amount of air, it should be maintained at 25 to 45 millimeters of mercury as pictured here. Should the provider overinflate the balloon, as pictured here, it is outside the normal range and the red button can be used to safely deflate the esophageal balloon to a safe cuff, in this case being maintained at 40 millimeters of mercury. In order to secure the Blakemore or Minnesota tube within the patient, you're going to use a rope or a curlex and tie several knots at the mouth of the tube. So as pictured here, nearest to where the ports and the balloons are accessible, please tie several knots as demonstrated above. Once those knots are secured, the tube can be safely placed to traction. In order to secure the tube to traction, please tie a knot around a 500 milliliter or 1 liter bag of fluid, depending on the order, 500 milliliters for 1 pound, 1 liter for 2 pounds of traction, using a standard knot as pictured in the video. Once the knot is secured, the patient can then have their tube placed to traction. In order to place the tube to traction, loop the curlex with the fluid bag over the end of a IV pole secured safely to the foot of the bed, so that way it can continue to hold traction. There should be at least 1 foot of distance between the bottom of the bag and the top of the bed in order to maintain that proper weight of